So today we're going to be talking about gut health. A day does not go by in my practice where I don't talk about gas, bloating, constipation, belly pain, colon cancer prevention. And the upshot to what I'm going to talk about is that, at least in primary care, most of the issues that I see aren't that mysterious or require extensive testing. Common things are common. And most of the time, for the various complaints I see in my office, there often are simple solutions to these problems: bloating, gas, constipation, etc. So today I'm going to cover kind of the 5 or so main GI issues I see all the time. I'd love you to ask questions in real time. Yes, Elizabeth, I'm going to I'm going to talk about reflux in this section. Um, and then ask me questions in real time. This is for you. This is about me, you, and your colon all in one place. So let's talk about IBS, so irritable bowel syndrome. A lot of my patients hate this diagnosis. They feel like it's a lazy diagnosis, a throwaway diagnosis, like doctors are too busy or disinterested to understand what's actually going on, and they just label their problems IBS. But the truth of the matter is that irritable bowel syndrome is real. It's a functional problem where there's spasticity and irritability of the colon. It's not an inflammatory process. It's not something that you can die from. It's not life-threatening. IBS is distinctly not dangerous. It can be very uncomfortable and very distressing, and it can interfere with people's quality of life. The classic symptoms of IBS are alternating bouts of diarrhea and constipation, bloating, gas, abdominal discomfort. This is so emblematic of our time. We have now different labels for IBS. IBS-C is constipation predominant IBS, and IBS-D is diarrhea predominant IBS. The naming and then the nomenclature doesn't matter as much as what is the underlying reason for your bowel irritability. People often feel helpless, particularly when doctors have said, look, your colonoscopy is normal, your lab work is normal, your stool studies are normal. I don't know what to tell you, it's IBS, and they send them on their way. So that is distinctly not helpful for people. Because again, IBS is real, it's distressing to people, and there are classic underlying causes that apply to a lot of people. So, what are the common causes? First of all, everything you put in your body, every single medicine you take, every supplement you take, every food and drink you consume is fair game. It can irritate your gut, right? It's entering in the gut, it goes through the gut, it has to go in one way and out the other. So when you're thinking about irritable bowel, it's really important to write down everything you're eating, or at least notice everything you're eating, everything you're consuming, and everything you're taking by mouth. The specific things the gut really does not like for most people, and this is a broad generalization, the gut doesn't like, in general, alcohol, caffeine, sugar, dairy, and for some people, gluten. This is not to suggest that everyone who drinks alcohol is going to have IBS or everyone who has gluten is going to have IBS. Not at all. But there's such a common theme here when I'm seeing people for IBS symptoms. If they cut back on alcohol and sugar, for example, they often feel better. There are certain medications that can irritate the gut. There are too many to mention. Obviously, antibiotics are known to irritate the gut, but there are many antibiotics, many medications that are not antibiotics that can irritate the gut. So it's important to document everything you're taking, including the fistful of supplements you may be taking. Because again, everything you put in your mouth has to be processed through the gut. And we got to be honest about what we're putting in there. Other things that can irritate the gut are the FODMAPs. So the FODMAPs are a class of foods. They're short term. What are FODMAPs? FODMAPs. They are short chain fermentable carbohydrates that are difficult for the small intestine to digest. Examples of FODMAP foods are like legumes, like beans. Alcohol is a FODMAP. Some certain fruits and vegetables are FODMAPs. So oftentimes we will tell patients who have IBS to remove all the FODMAPs from their diet. Sometimes when I give patients the list of FODMAPs, though, I'm not going to say sometimes, commonly patients are like, oh my gosh, you're telling me not to eat anything on this list? If I eat nothing on this list, I will be eating like a cardboard box. And that is actually true. If you eliminate everything on the FODMAP list, you're going to have a hard time nourishing yourself. So, sure, if you wanted to be strict and do a strict elimination diet to figure out what, if any, of the FODMAP foods are irritating your gut, you could eliminate everything on that list for 2 to 4 weeks and then see if your gut improves. If it does, slowly add things back. But I find that for most mortals, that is difficult to do. Instead, I will just ask people to like pin that list of FODMAP foods to their refrigerator and notice what they eat on a regular basis and notice if there's any correlation between what they're eating, like chickpeas, and their irritable bowel symptoms. So the other thing about IBS is it's very much emotional. It's not to say that everyone who has IBS has anxiety or OCD or some emotional problem or they're mentally ill. Not at all. It is to say that the gut is the home of many of our emotions. Most people recognize the relationship between, say, travel and constipation. Why is it that when we travel, when we go on a flight and go somewhere else, we get constipated? It's not because we're mentally ill. It's because there's an emotional component to it. There's a physiology that we cannot measure that causes the gut to slow down. Some people will notice, for example, when they get very anxious before a big presentation or before some, big life event or after a big life event, they get loose stool or diarrhea. That's not because they're mentally ill. Again, that's because anxiety lives in the gut. So I want people to be honest with themselves when they're looking at the causes for irritable bowel syndrome about how they're doing mental health wise. How are they processing stress? How are they managing anxiety? Where is anxiety living in their body? And is it possible that anxiety is not being metabolized, so to speak, in a healthy way with, say, exercise or with therapy or journaling? And is your gut a victim of your stress? It's very easy to get a bunch of blood tests and get some stool tests and it's, relatively speaking, compared to the act of looking at yourself in the mirror and saying, wow, I have a lot of pressure on me. I have a lot of emotional distress, and maybe it lives in my gut. It's also harder to prove the cause and effect. But I would say I see it all the time. Patients who have unaddressed stress and anxiety or depression or insomnia, they have IBS. Not universal, but it's something to consider. Okay, let's move on to the next thing. We talked about IBS. Next topic we're going to talk about is GERD. GERD, gastroesophageal reflux disease. What is this? So some people call this heartburn. I wouldn't call it heartburn because that is not representative of the symptoms that a lot of people experience. What is GERD? GERD is when the acidity that lives in the stomach, right below your breastbone, rises up into the chest. Acidity in the stomach is normal. The stomach has a mucosal lining that has proton pumps, and it makes acidity to help you digest food. When that acidity goes in the wrong direction, it goes northbound instead of southbound, it's called reflux, GERD, gastroesophageal reflux, meaning that the acid is going from the gastric container to the esophagus, which is up north. So how do people experience this? I mean, the classic GERD patient is someone who has heartburn, in quotes, after they eat a pizza and have a couple glasses of wine, and they lie down at night and they feel that sort of burning in their esophagus. The esophagus is typically a little leftward from the midline. And that's when it's easy to make that diagnosis. What are other manifestations of GERD or reflux? Well, some people just have a chronic cough. Patients often don't believe me. When they come in, they say, Doc, I've been coughing for 2 months. I've had allergy testing. I've taken cough drops. Maybe I need an x-ray. Maybe I need a CAT scan on my chest. And when I dig deep enough, it turns out that their cough is worse at night. And it's worse when they've had a late dinner. And it's worse if they had acidic foods or drinks at dinner. So what I'm saying is that one of the symptoms of GERD is cough. Acidity that rises up into the chest can cause irritation of the vocal cords and the larynx. And there's something called LPR, which is laryngopharyngeal reflux, where acidity goes into the esophagus and into the laryngeal cavity and causes cough. It can also cause sore throat. It can cause even sinus symptoms. And of course, excess stomach acid can cause just gastritis itself. GERD is when it goes upwards, but gastritis is when the stomach acid is just sitting there parked in the stomach and causing irritation and causes an upper GI bellyache. So what are the common causes of stomach acid overproduction or stomach acid excess and then stomach acid that goes in the wrong direction? Commonly, Advil, ibuprofen, Aleve, NSAIDs, all that class of medications can irritate the stomach lining and cause increased acid production. What else? Certain medications. Steroids, for example. I'm talking about prescription medications. Steroids, there are a whole host of medications that can cause gastroesophageal reflux. Food. So acidic foods and drink. One of my favorite books to recommend to my refluxing patients is called Dropping Acid. Play on words. Taking acid out of the diet or reducing the intake of acidic foods and drinks can really help patients. So the common culprits are acidic foods and drinks like wine, coffee, and not just coffee, but caffeine. Vinegar, tomato, citrus, other citruses like lemon and lime. So, patients will often have a healthy dinner with, say, vinaigrette and tomatoes in the summer and a glass of wine. And guess what? That's relatively healthy. Having a glass of wine can be fine at night. But if you're dumping a lot of acid into your stomach and you've had a stressful day, which increases your stomach acid production, you might have reflux, especially when you lie down and you don't have the benefit of gravity for the acid to go down. So what can cause acid overproduction is acidic foods and drinks, certain medications, particularly the NSAIDs, and then, of course, emotional stress. I always go back to emotional stress, but it's relevant to every kind of organ system we talk about. So stress can make our stomach acid increase. It's physiologic. You've heard of the stomach ulcer problem when people get overly stressed, like, oh, I think I'm going to get an ulcer. I'm so anxious. That's because emotional distress causes acid production to occur, and people can then have gastritis or esophageal reflux. What else can cause reflux? Just position. So even if you have a normal acid pump in your stomach, like you're producing normal amounts of acid and you don't overconsume acid in your diet, if you eat late at night and you lie flat, you're at higher risk for acidity rising up into the chest and having reflux, whether it's heartburn or cough or sore throat the next morning. So one of the solutions I recommend for patients when they're trying to figure out how to deal with their reflux is, of course, reduce acidic foods and drinks. Pick up a copy of that book called Dropping Acid. Look at your meds list. Make sure there's nothing in there that's obviously increasing stomach acid production. Elevate the head of your bed. It's not just more pillows, but like there are these wedge pillows you can buy to elevate the head of your bed, so that you have the benefit of gravity, bringing acid downwards instead of northbound, and then also eating earlier in the evening. I wish I did this. I wish I was like the Leave It to Beaver crowd where I ate at like 5:30 p.m. That sounds like heaven to me. We usually eat late. But if you're able to eat earlier, that is ideal too. And then manage your stress. Wouldn't that be nice? That's easier said than done, but think about what the stressors are in your life and how you could better manage them so that your stomach acid isn't churning all the time. Someone's asking here, does GERD lead to burning mouth syndrome? It can. I mean, burning mouth syndrome is one of those things that's super hard to figure out, to diagnose or what I should say more specifically, to find the cause for. I've had people have burning mouth syndrome because of various toothpastes, because of an intolerance to a dental procedure, but certainly acid from the stomach rising up into the mouth can be a cause. Okay, what is the next one? So we talked about IBS, we talked about GERD. Now we're going to talk about bloating and gas, my favorite. So this is a very common complaint. I should say what I said up front, which is that of course you want to talk to your doctor about these symptoms. Bloating and gas can be a sign of ovarian cancer. It can be a sign of early colon cancer. It can be a sign of diverticulitis. But what I'm talking about is the symptoms that you have when you've already done the rule out. You have a normal colonoscopy, you've done the evaluation with your doctor for the basic fundamental issues, and you still have bloating and gas. So the common reasons for bloating and gas are a lot of what we talked about already. Sugar-free gum is notorious. So sugar-free gum, sweeteners, those mints that are sugar-free. Some people really don't tolerate that and they have gas. Advil, just like it can cause reflux, can cause bloating and gas. Too much fiber. I have patients who are so good about getting fiber in their diet because they know it's good for their cholesterol and it's good for their digestive health, but your body can only take so much fiber. So you might ask yourself, if you're bloated and gassy, are you giving yourself too much of a good thing? Eating too quickly. If you eat quickly, like I sometimes do at dinner or at lunch at my desk, you can get bloating and gas later. Also, not moving enough. If your body isn't moving, your gut is sitting there too quiet and it needs to move to get things going. So those are my basic sort of high level um, talking points about bloating and gas. Of course, the FODMAP foods, which I talked about earlier, can cause bloating and gas. Bloating and gas is one of the features of irritable bowel syndrome. Okay, constipation, another favorite subject. Constipation is most commonly a result of the lack of adequate dietary fiber. Um, so it's important to get roughage in your diet. Fruits, vegetables, leafy greens, oatmeal, fiber, 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 fiber. If you're someone who still gets constipated, and you've had a normal colonoscopy, because of course colon constipation can be a sign of colon cancer. Much more commonly, constipation is just slow motility through the colon. Um, then think about how much fiber you're getting. Think about what medications you might be taking. If you're taking a GLP-1 medication like Ozempic or Mounjaro or Wegovy, it would not be surprising to me to hear that you're constipated. It's one of the known side effects of those medications. Um, but some people just have chronic constipation. Like they were constipated when they were in middle school and they're constipated in their 50s, 60s, and 70s. And it's really uncomfortable. It's really unpleasant for people. And then when they travel, it makes it even worse. So what are the things I recommend to people who have chronic constipation, which could be called IBS-C or irritable bowel syndrome, constipation predominant? I just call it constipation because I don't care about the nomenclature. I just care about the patient in front of me. But what do I recommend? Common, easy fixes or attempts at solving this problem involve Colase. I love Colase. Colase is a stool softener. Colase is very safe. Of course, talk to your doctor. Don't take my word as the gospel. But Colase in general is an over-the-counter stool softener, is very safe. It's Docusate, Docusate. Usually I prescribe it 100 milligrams once a day or twice a day. I don't prescribe it. I recommend it because it's over-the-counter. It's non-prescription. I also really like magnesium as a supplement at bedtime for patients. Magnesium citrate, magnesium oxide, either 400 or 500 milligrams is a nice way to help with muscle relaxation, constipation, and for some people, sleep. One of my patients loves Swiss Chris. It's funny, every time I see her every year, we talk about Swiss Chris because it's like her favorite thing. She was constipated her whole life, and she finally got Swiss Chris, which is an over-the-counter supplement, and it's helped her a ton. Um, what else? I think that movement is helpful. So patients often get constipated because they are sedentary. So getting regular exercise, getting regular hydration is key for bowel motility. And then again, I go back to the stress thing. Stress for some people causes constipation. Stress for other people causes diarrhea. Stress for other people causes bloating and gas. So again, when you're thinking about your gut health and you're having irregular bowels or you're constipated and you've done all the due diligence with your doctor, colonoscopy, lab work, ask yourself, journal it out. What is going on in your life? Are you stressed? Are you anxious? Are you overwhelmed? And what are you doing about it? And if you can connect the dots between when you are stressed and anxious and when your gut is bothering you, that can be a very handy tool. Some of my patients actually use their gut as their sort of check engine light for when they know they need to do better with self-care, sleep, healthy eating, seeing their therapist, doing more journaling, etc. This is not universal. It's not to say that everyone who's constipated is anxious. It's not to say that constipation shouldn't be worked up by a doctor. I'm saying that common things are common, and a lot of times these very common gut issues have simple solutions. And it's often about the things you put in your mouth, about your physical mobility. It's about taking an honest inventory about every single thing you take, supplements, vitamins, medicines, and then addressing emotional health. Of course, there are red flags. If you have red flags with your gut health, with your gut symptoms, you need to see a doctor right away. Red flags like blood in the stool, unintentional weight loss, severe abdominal pain, vomiting that won't stop, family history of colon cancer. If you haven't had your basic screenings with your doctor, please go do that. Let's talk about colon cancer. So, colon cancer is screened for commonly with the colonoscopy. That's the best way. That's the best modality for colon cancer screening is a colonoscopy. I predict in the future we won't have colonoscopies as the standard way of screening for colon cancer, but that is today in 2025 the best test we have for colon cancer screening. The goalpost, the age we used to recommend colonoscopies at used to be 50, and the goalpost has been moved to 45. So now, if you're 45 years old, you should get a screening colonoscopy. You should get a screening colonoscopy earlier if you have a family history of colon cancer, particularly if that family member is a first-degree relative, a mother, a father, a sibling who had colon cancer before the age of 50 or 45. So talk to your doctor about when you should get screened, but suffice it to say that it's earlier than it used to be. And colonoscopies are a hard sell. So it's hard for me to convince a healthy patient who has normal bowel movements and normal blood work to get a screening colonoscopy. Unsurprisingly, no one loves. Actually, I have a patient or two who actually thinks it's kind of pleasant. They like the sort of cleanse feeling. But most people, I would say, don't love the idea of drinking a bunch of disgusting tasting liquid, pooping their brains out, and then going to see a doctor to put a tube in their bottom to take a look for polyps or precancers. So I don't blame them for not wanting to do it, but I would say it's the best way of screening for colon cancer. Not only can the colonoscopy look, or the doctor who's looking at the scope and looking at your colon detect colon cancers, they can also detect polyps, which can become cancerous. And at the time of the colonoscopy, they take those polyps off. So it's not only a diagnostic tool, it's a therapeutic tool as well. Unlike a virtual colonoscopy where they can't actually take out polyps that may or may not be seen, the colonoscopy is a great way to take out polyps that will never become cancer because they've been removed. So I hope we live in a world someday where we don't have colonoscopies as the standard of care for colon cancer screening, but that's where we are today. Patients often ask me about Cologuard. What about Cologuard as a way of screening for colon cancer? I think that technology is pretty amazing. The Cologuard test is a kit that comes to your home, and your doctor has to order it, and it looks for the genetic material of colon cancers in your stool. It's a stools test. The problem with the Cologuard is that it's not as sensitive as the colonoscopy. It also cannot take out a polyp, right? It's not a procedure. It's just a poop test. So I think, who knows? I shouldn't be in the prediction business, but if I were to guess, I would guess that in the future we would have more sophisticated stool testing to screen for colon cancer. But for now, get your colonoscopy. The prep is temporary, that prep procedure, but the peace of mind can last years and years and years because colon cancer is out there. The other thing I would say is don't assume that rectal bleeding is always from hemorrhoids. So rectal bleeding can be from hemorrhoids, that's the common reason, or from an anal fissure. But any rectal bleeding, any change in bowel habits, and of course, changes in your family history should warrant a conversation with your doctor about whether it's time to get your first or next colonoscopy. When I say change in bowel habits, I don't mean like you travel and you get constipated on a trip. That's not a change in bowel habits that warrants a colonoscopy necessarily. I'm talking about hopefully you know your bowel movement habits. Let's say you have a change in your bowel habits that lasts more than a few days, that last weeks or months. That's something that's what I would call a change in bowel habits that is worth calling attention to with your doctor. Okay, what questions do you have? Can you talk about the Lynch syndrome and colon cancer? So Lynch syndrome is hereditary polyposis. Lynch syndrome is a genetic and inherited disorder where the colon has lots and lots of polyps and people are at higher risk for colon cancer. Lynch syndrome is real. It's pretty uncommon. And it's something you can check for in genetic testing, but the first thing to do is get that screening colonoscopy. If you go in and have your first colonoscopy at 45, your doctor is going to pretty well be aware whether you have Lynch syndrome or not. That said, it's possible to not have tons and tons of polyps and still have Lynch syndrome. So if you have a family history of Lynch syndrome, I would get genetically tested through a geneticist and not just do the colonoscopy. Um, what other questions do people have? I've seen some questions popping up. Um, does acid reflux GERD include morning nausea? Absolutely. So nausea can be from many things, but reflux and excess stomach acid or stomach acid that rises into the chest and into the back of the throat can cause nausea. In fact, a lot of nausea in general, whether it's seasickness nausea or nausea from the norovirus that I got hit with this winter and hope I never get again, the nausea is the presence of stomach acid that is physiologic. In other words, when you get nauseated because you've got a stomach bug, it's your body's way of fighting the virus and making you feel sick in the meantime. So what are the upshots here? Our gut is often the home of our emotional health. It's not the only home, but it is a cozy home for anxiety and stress to park. So make sure you're addressing your emotional health when you're perplexed about what's causing your bloating, gas, diarrhea, irritable bowel syndrome symptoms. Um, and then be sure to take a good inventory about your meds, your vitamins, your supplements. Understand the relationship between the cadence of your eating, the timing of your eating during the day, and your gut symptoms. It's amazing when we just insert a little consciousness into our everyday habits and then connect the dots between, oh, maybe I skip lunch on these days and then I feel bloated and gassy that afternoon. That's a big insight. Maybe it just means you need to have a fiber-rich lunch or lunch at all to help your bowel motility so you're not bloated and gassy. Again, common things are common. A lot of the solutions for basic gut complaints are right under our noses, but and don't really, frankly, require a doctor. They just require a little bit of detective work on your part and taking stock of your meds, what you eat, the timing of how much you eat, being honest about how much alcohol you drink. One of the more common issues that I see is alcohol-related irritable bowel syndrome, um, gassiness, bloating, diarrhea, not to mention a whole host of other symptoms that don't relate to the gut. And then, of course, getting your colonoscopy, seeing your doctor, getting your labs checked, because GI symptoms can be a manifestation of larger medical problems, and that's always important to address too. Um, what? How to live with Schatzki's ring? I would be lying if I told you I was the world's leading expert on Schatzki's rings. But as far as I know, so Schatzki's rings are those like esophageal rings. That's not fair because I'm saying the definition of the word in my description. But they're like inflammation in the esophagus that can make it difficult to swallow. It can make it difficult to get food down. Um, I wish I had more nuanced advice about that, but you would see your GI doctor and get an upper endoscopy to make the diagnosis. An upper endoscopy is where they take a scope from the mouth all the way down your esophagus into your stomach, and they look at the Schatzki's ring. And sometimes people will have dilatation of the Schatzki's ring. But please don't take my advice about Schatzki's ring. I would see your GI doctor. That is a subspecialty. That is the place to go. What else are people asking me? Years of diarrhea. This person is saying, "Hi, Janet. Sorry to call you out about your diarrhea, but you're writing it publicly. Years of diarrhea, colonoscopy normal, tried FODMAPs, but so limited, had major weight loss a year ago. So many things I can't eat, such as tomatoes, salmon, chocolate, alcohol, onions, sugar. I feel like it's a gamble every time I eat." That sounds awful. I'm so sorry to hear that. That sounds like IBS-D. I am not going to make a diagnosis on a live video on a social media platform. But first of all, I feel your pain. That sounds awful. Second of all, do what I talked about in this ditty here. Look at your meds. Look at what you're eating. Think about emotional distress. Try fiber. Fiber is the unsung hero of the gut. So IBS is, as I talked about in the beginning, this sort of kind of umbrella diagnosis for irritable bowel, twitchy bowel, that is often related to foods and medicines and emotional distress. Doctors don't love talking about it because there isn't a fix, and the conversation about it is quite nuanced. It can take some time. What we often fail to do is recommend the number one treatment for IBS, which is fiber. So whether you have constipation or diarrhea predominant IBS, taking a daily Metamucil or taking a daily Citracel can often be very high yield. So a daily fiber supplement can help bulk the stool. I think of fiber by supplementation as a stool organizer. So it helps your stool move through your colon in a more organized fashion instead of doing what it's doing with you, Janet, which is diarrhea. And then, of course, seeing your doctor to make sure that you're not missing something else. Certainly, there are diseases of the colon and the esophagus and the small intestine that can be quite serious and warrant significant medical attention, like inflammatory bowel disease, Crohn's, ulcerative colitis, esophagitis, H. pylori, stomach cancer, colon cancer, esophageal cancer. Those things do exist. So, of course, see your doctor when you're having these symptoms. But I hope this has been helpful to think about the sort of simple, everyday ways to mitigate common GI complaints that may be just right under your nose. Anybody have any other questions before I sign off? I also want to remind you that next week, maybe I haven't said this yet, but next week, Tuesday at 5 p.m. Eastern, I'm bringing my friend Rachel Rubin, who is a leading expert on genitourinary health. Rachel Rubin is a hoot. She's hilarious. She's also she's a urologist who is talking all over the country, as she should, about the benefits of vaginal estrogen for menopausal women. She talks about hormone therapy. She talks about men's health, women's health, sexual health. She is joining me next Tuesday at 5 p.m. Eastern. And then the Tuesday after that, I'm being joined by Mary Claire Haver, MD, who is a nationally recognized menopause expert whose book, The New Menopause, has been on the New York Times bestseller list for something like 35 weeks in a row. It's crazy. She's amazing. Rachel's amazing as well. So the next 2 weeks, I'm going to have these two doctors talking about genitourinary health for men and women, and then Mary Claire Haver talking about menopause health. So the new time for this podcast, live, unscripted, unedited, as you can tell, is 5 p.m. Eastern on Tuesdays. And I will see you next week. Thank you guys for joining me. It's always fun. And thank you for your questions.